Hello everybody, thank you for joining this webinar. My name is Nikki Raskowski and I'm an education specialist with SUNY Upstate. This webinar today is on HIV pre-exposure prophylaxis. This webinar is ideal for anyone who works with folks who could be at risk for HIV, and we'll spend the next 45 minutes or so talking over the basics of PrEP so that you will be able to talk hopefully confidently to others about what PrEP is and how they might use it. So let me share my screen and we'll get started. What are we going to cover today? Well, we're going to talk about ending the epidemic, the HIV epidemic in New York State. We're going to cover briefly the 2018 data. It's important that you know who is especially affected by HIV, where those health disparities lie, so that you can go above and beyond to hopefully reach those folks with some of our prevention tools. I'm going to talk about U equals U, and then finally PrEP, and I'll take any questions. Hopefully you'll bear with me a little bit as I go through the ETE data, U equals U, because it really puts into context what we're talking about with PrEP. And without covering those things, I think it's very hard to really understand PrEP's place. So we'll cover those first, then we'll move on to PrEP. Ending the HIV epidemic in New York State. In 2014, Governor Cuomo released a blueprint to end HIV by 2020. Specifically, we're looking to bring the number of new HIV infections down below 750 this year. So we're shooting to have less than 750 people infected this year. That's the goal. It's an ambitious goal, and it's hard to say whether it will be achieved or not. But what is very positive is that there's been a lot of work done over the last 6 years to bring the number of new infections down, and there has been a significant decrease. It's a three-point plan. We've got to get people tested for HIV, first of all. There is not enough testing happening. There's not enough access to testing for those who need it. What would be wonderful, the dream is to have testing, HIV testing normalized, so that people who, people who go to their doctor, regardless of their age, gender, race, socioeconomic status, all of these things, they're just offered an HIV test. It would be so nice to see HIV testing looked at in the same way that a blood pressure screening is. I go to my primary care doctor and I expect that they'll take my blood pressure every time. I know that's not based on any assumptions they're making about me or any judgments, or they just do it every time and I expect it. Wouldn't it be wonderful if we got to that with HIV testing? Unfortunately, that's not the case. And many providers, I think, still feel that when they offer HIV testing that they may offend their patients, or that there potentially is something wrong with doing that, and often feel the need to justify it in the way they ask the question. You know, you might have been offered an HIV test where they say, you know, the state says we have to offer this. You don't want an HIV test, do you? And it's actually quite hard for many people to say yes once you framed it in that way. If they were, in fact, to say, it's standard that we do HIV testing, I'd like to run an HIV test today, is that okay? You'd be much more likely to get people saying yes. So we've a lot of work to do with testing. We also need to educate community on seeking testing, making testing a normal part of their sexual health. So there's a lot of work to be done. The more people we can test, the more people we can find who are HIV positive and undiagnosed and get them into care. So the next part of this three-point plan is to get those people who are HIV positive into care and taking medication. Ideally, we want those folks with an undetectable viral load. So we have many people living with HIV in New York State, and not all of them yet have an undetectable viral load. Some of them don't know they're HIV positive yet. Some people know they're HIV positive but are not in care. You know, they don't have a doctor, an HIV doctor, they don't get their HIV meds. Some of them are in care but not taking their medications consistently. Some of them are in care and taking their medications. And if that's the case, they probably have an undetectable viral load, or they're heading in that direction. When we talk about an undetectable viral load, when somebody's HIV positive, there are particularly two important measures that they need to know and we need to know. One is their viral load, that's the amount of virus they have in their blood. And the other one is their CD4 count. So those CD4 T cells are white blood cells that are an essential part of our immune system. And HIV uses those cells to replicate. So HIV, particularly if it's been untreated or somebody has been HIV positive a while and not had any medication, they may have fairly low numbers of those CD4 cells. We need people to have an undetectable viral load, it's the amount of virus in their blood, because when they have an undetectable viral load and have sustained that for 6 months or more, they can't transmit the virus to anyone else through sex. So that's a really fantastic way for us to stop transmission. And also, we obviously want to make sure the people living with HIV are healthy and well and live long lives. The third part is PrEP. That's what we're here to talk about today. A daily medication that prevents HIV, taken by somebody who is at risk for HIV, but HIV negative. So PrEP is for people who do not have HIV and are trying to avoid getting it. So running through some of the numbers here, we have seen a really significant decline in new HIV infections and those being diagnosed with HIV. Between 2009 and 2018, it was a 43% drop. Statewide, though, we are still seeing too many people who are diagnosed with HIV and concurrently diagnosed with AIDS. So we classify somebody as having AIDS when they have a CD4 count below 200. That's the kind of marker often that somebody's immune system is not doing so well. I told you those CD4 T cells, white blood cells, that our immune system, that they're required to keep us healthy and to fight off invading diseases or illnesses. So what this tells us here is that if 21% of people who are newly diagnosed with HIV, they take an HIV test, it comes up positive, are being diagnosed with AIDS at the same time, then those are people who are likely not newly infected, right? Because I suspect you already know with HIV, it takes a little while for the damage to really show, right? HIV can go for many years with people having no symptoms at all. And during that time, the HIV virus is just slowly chipping away at the immune system, at these CD4 cells, because it's using them to make copies of itself and they get destroyed. So if somebody's coming to us for their first appointment and they already have AIDS, they've likely had HIV for a while, their immune system is damaged, they could have been infecting people unknowingly while they were undiagnosed, and also their own health is not in good measure. So we want people to get tested frequently so that this doesn't happen. So that's still a lot of people who are being diagnosed with AIDS and being diagnosed later than we would like. And it should be noted that that number is higher for transgender men. So we need to do more work around testing for trans men. We also see fairly significant health inequalities, seeing that people of color, especially men who have sex with men and men who have sex with men and women, are at much higher rates, a much higher chance of getting HIV. The rates are much higher. So we know that we need to direct some of our prevention efforts into communities of color with culturally appropriate, high quality prevention tools. So let's just talk a little bit more about U equals U. So I already mentioned this. Somebody who has an undetectable viral load and has sustained it for 6 months or more cannot transmit the virus through sex. So what we're trying to do with all of our patients who are living with HIV is make sure they have this undetectable viral load. So the amount of virus in their blood is so low that we can barely pick it up. They're still HIV positive. If they stop taking their meds, that number will go up again. But while they're undetectable, as long as they've sustained it for 6 months or more, they cannot transmit the virus through sex. That's a really big deal for those people who are living with HIV, because that really empowers them to stay undetectable. It helps reduce the stigma around HIV. It also has some implications with PrEP. So now that we know this for sure, we suspected it might be the case for a while, but we have the research to show this. It actually now means that when we have two people in a relationship where one is HIV positive and one is not, that person who is HIV negative may have been on PrEP before. If the person who's HIV positive has been undetectable for some time, which is the case with many of our patients, that negative partner really could, if they want, come off PrEP. Many couples in that situation choose actually to stay on PrEP just from it just eases their anxiety and worry around the negative partner becoming HIV positive. But it's nice to know that they don't need that anymore. It also has disclosure implications. So if we know that somebody has an undetectable viral load, they don't need to then disclose that as much maybe as they would before. It means that if they know they can't transmit the virus through sex, that maybe they can hold off on disclosing to partners a little bit longer. Because you have to remember that anytime somebody who is HIV positive discloses their HIV status, they put their lives in real danger. You know, it's still, there's so much stigma with HIV. And there have been times where people have been attacked or murdered for simply being HIV positive. So we shouldn't diminish what risk those people put themselves in every time they disclose. And it's an important component of ending the HIV epidemic. If we could have everybody who was HIV positive to have an undetectable viral load, then we would effectively end the HIV epidemic in its tracks, because the virus couldn't be transmitted because everyone was undetectable. No one else would get it. And we would end this thing. Unfortunately, we're not there yet, but it is a really important component. Before we move on to PrEP, I want to just talk about PEP, because these are often confused, and whoever came up with naming them PEP and PrEP it didn't help us out much. PrEP is pre-exposure prophylaxis, a daily medication taken by somebody who is HIV negative but at risk for HIV, and it's going to keep them HIV negative. PEP is medication taken after a potential exposure to HIV. So I often, when I do education in the community, tend to compare these to birth control. PrEP is like the contraceptive pill. You take it every day, and if you do take it every day, it's going to prevent you from becoming pregnant. If you stop taking it, then you could get pregnant again. PrEP is like that, but for HIV, and it's appropriate for men and women, cis and trans. So with PrEP, you take it every day. While you're taking it, it's going to prevent you from getting HIV. If you stop taking it, you can get HIV again. Very similar to the birth control pill. PEP, however, is much more like the morning after pill, or Plan B. There's something, there's unprotected sex, then that medication can be taken after that unprotected sex, or because with HIV, it could be anything that puts someone at risk. But for this example, we'll say they have unprotected sex, worried about contracting HIV. They can take medication after that incident to prevent them from getting HIV, much like somebody has unprotected sex and they're worried about getting pregnant, that they would take the Plan B after. Now, PEP is a little different to Plan B in that it is actually 28 days worth of medication, but the concept is the same. It's taken afterwards. 28 days of medication taken after to keep someone HIV negative. What's important to note with PEP is that it needs to be taken within 3 days of the exposure, and really on that third day is not especially effective. So it's important, if you're educating others on this or just for your own knowledge, that if something happens where you or someone in your family, something happens where they could have been exposed to HIV, maybe, occasionally we see maybe a child picks up a needle in the park. Unfortunately, there is some needle waste around, and you don't know if they got stuck by the needle. You could take them to the emergency room and they would get medication, and we can give this medication to kids as well. This is appropriate for children. They would take medication for 28 days and it would make sure they didn't get HIV, but you've got to go quickly. So much like the morning after pill, the sooner you start taking this, the more effective it is. So don't wait 3 days because it's not going to be very effective. If something happens, you go immediately to the emergency room and you get the medication. If you take it in the first day, it's very effective. And even in the second day is pretty effective. So PrEP offers the ongoing protection. If somebody's on PrEP, they won't need PEP. Just like, again, we'll use that example. If someone's on the birth control pill, they take it every day, they don't need the morning after pill because they're already covered. They're already taking their birth control, and this is a similar concept here. So what is PrEP? Well, PrEP is a daily pill, either Truvada or Descovy, taken to prevent HIV. Truvada and Descovy are both antiretroviral medications. They're medications that we do use for people who are HIV positive. When somebody's HIV positive and taking medications, they actually need a minimum of 3 different medications to effectively reduce their viral load or keep them undetectable. Somebody who's on PrEP actually only needs 2 medications, not the 3. So both Truvada and Descovy have 2 medications within them. So most people now, Descovy is the medication that's been, that is now used for PrEP. It was approved for use about a year ago now, but we tend to use Descovy, but we can certainly still use Truvada. So they would use either or, but both of those medications, both Truvada and Descovy, contain 2 medications. Somebody who's HIV positive could take one of those meds, but they would take something else as well. So for prevention, they only need either or. For people who are HIV negative, this is a very effective system to prevent HIV. It's a harm reduction tool. So we're trying to reduce somebody's risk of HIV. We're trying to also, if it's appropriate, if it meets the individuality of the patient, we're also trying to reduce their risk of other STIs or other harm potentially. So we're going to do STI testing every time they come in for a visit, even though, you know, the HIV testing is a part of this, the STI testing is as well. So anyone on PrEP has to have regular STI testing. And they're going to come in for either 3 or 6 monthly visits, depending on their complexities. If they're a more complicated patient, we're going to see them more often, or if maybe they just want to see us more often, we'll see them every 3 months. If we don't need to see them that often, we would see them every 6 months. Upstate provide PrEP. So we have 3 different clinics providing PrEP. Pediatric Infectious Disease Clinic, which is where I'm based. Adolescent Gender Clinic with Dr. Thielen. She also sees a lot of transgender and gender diverse patients, but she will prescribe PrEP. And then Inclusive Healthcare Services, who are now taking patients for LGBTQ specialty primary care as well. They'll provide PrEP. So let's just cover for a moment who could need PrEP. What groups of people might be at risk for HIV and might benefit from PrEP? Well, broadly, anyone who is having unprotected sex with a partner of unknown HIV status, and that really applies to a heck of a lot of people. We need to be broad and open-minded when we consider who's at risk for HIV and who could be a good candidate for PrEP, because we need to be careful that we're not stigmatizing groups, and we're not, you know, for example, that we're not saying PrEP is something for gay men because gay men get HIV more. Gay men do experience HIV at a disproportionate rate, and they are one of the populations that could be good for PrEP. But there are so many more people who are good candidates for PrEP as well, and there are plenty of gay men who are not remotely at risk of HIV. So it's good. We want to keep an open mind here. Somebody who has an HIV positive partner could be a good candidate for PrEP. I say maybe because we talked about U equals U. If they've been undetectable for years, or for 6 months or more, then maybe they don't need it. If that works for them, if they're comfortable and happy, then maybe they can go without. Usually, if the HIV positive partner is undetectable, the only reason we're prescribing PrEP really is for you know, to deal with the worry that they might have about HIV. For many people living with HIV, the fear of infecting somebody else is really significant. We're also going to consider anyone who has a history of STIs to be a good candidate for PrEP. So if somebody has had another sexually transmitted infection, then they are likely a good candidate for PrEP, especially if they have had syphilis. That often is one of those red flags that somebody is at risk, at significant risk for HIV. So if you have clients or know someone who's had syphilis, talk to them about PrEP if they're still HIV negative, because they're on that road. People using drugs, and I don't say people using injectable drugs, because it's not just people who are using injectable drugs that could be at risk for HIV. Drug use, injectable or not, can change our ability to make good choices. Not always, but it can. Particularly if somebody is addicted or dependent on a certain drug, then it may be that they need to engage in high-risk behaviors to be able to afford to get drugs. So, sex work would be an example there. But if somebody's using drugs, that may well come with some higher risk behaviors. As I say, it might not as well, but worth considering. Somebody who has a history of sharing needles, absolutely. Repeated post-exposure prophylaxis. So if we have someone who keeps using PrEP, well, they'd be far better on PrEP. PrEP, the post-exposure prophylaxis taken afterwards, often does have some unpleasant side effects, like some GI issues, maybe some diarrhea, headaches. PrEP is not repeated. You wouldn't want to keep taking this when you could be on PrEP, which usually has no side effects. We can also prescribe to anyone who's just worried about HIV. What we have seen time and time again is people come into our clinic and they're brand new with us, and they tell us they want to start PrEP, take a sexual history, and they appear to be very low risk. They really don't present as someone who has much risk for HIV at all. What we've learned, though, over time is that these folks often, particularly because we're in pediatrics, seeing under 24-year-olds, is that on many occasions you don't get the whole story on the first visit. It takes a little while for them to know that they can trust you enough to tell you. And so we, with one exception, which was an exceptional case, there was something else going on, even if someone appears to be very low risk, if they want PrEP, we'll prescribe. And almost always we see that there's a lot more going on than they had initially reported. We can also think about PrEP for people who are in groups that are disproportionately affected by HIV. For example, Black gay men actually have a 50% chance of getting HIV in their lifetime, which is staggeringly high. And the reality is that they don't necessarily, and there was a study that backed this up, engage in any higher risk behaviors than white gay men, but just with all of the disparities that apply to many other diseases and people of color apply to HIV. But then also with diseases like HIV, people tend to have sex with other people of the same race, generally, as a generalization. And that means that in this case, Black gay men are actually working in a smaller sexual network. Just the numbers of Black gay men, for example, in Syracuse, that group, that number of those who are Black gay men in Syracuse is much lower than the number of white gay men in Syracuse, just by the makeup of the population. And if people tend to have sex with other people of the same race, it just means that when an STI gets into a group or a sexual network, it goes much faster. So what I'm saying is that a Black gay man may be engaging in much lower risk behavior than a white gay man, but just the numbers alone, unfortunately, mean that he is more likely to come across somebody who is HIV positive in that smaller sexual network and be exposed. So I want to point that out, because I don't want you leaving this thinking that Black gay men engage in higher risk behavior. That's not what we see at all. all of those other factors. So what I'm also saying here is that if you, again, we'll use this example, have a Black gay man that you work with, it would be a really good idea to talk to him about PrEP. Just knowing that the rates are so high, 50% chance in someone's lifetime is incredibly high, and we want to do everything we can to change that. Barriers. So barriers to PrEP, whether they're real or not, these are barriers. If somebody believes a barrier to be a barrier, then it can be a barrier. So PrEP only prevents HIV. It doesn't prevent any STIs, and it obviously doesn't offer any pregnancy protection either. And for some people, when we say that, they say, oh, well, I may as well just use condoms. Fantastic. Condoms are definitely, from a public health perspective, condoms are better because they do offer all of that protection from other STIs. So yes, fantastic, continue with condoms. Really, we're looking in most cases at PrEP for people who are not using condoms, rather than having people who are move away from using condoms, but it depends on the situation. So that could be a barrier that people don't think it's worth it. Low perception of HIV risk. This is definitely a significant barrier. People believing that they are not at risk for HIV, or that their risk is very low, when in reality that's not the case. That is a big problem. Adherence. So what I mean by that is certainly a barrier to PrEP is if you have somebody, or we have somebody, who is not taking their medication. It should be noted though that if somebody's going to take their medication 4 days or more a week, it does offer pretty good protection, so it's still worth it. Not 99+%, which is PrEP, if it's taken every day, is over 99% effective. However, if their adherence is not good, if they're taking it 4 days a week or more, it offers enough protection to be worth prescribing. But say they're taking it once or twice a week, that's not helpful, and actually could be a real problem, because if they were to get HIV, to seroconvert and get HIV, the chance then of them becoming resistant to whatever medication they're taking is fairly high. So I told you already, Descovy and Truvada are both HIV meds, and if people become resistant to those, then that's a real problem. So that's the other reason we do HIV testing every 3 months. Stigma certainly is a really damaging barrier to PrEP. When PrEP was first kind of released for use in the US, there was online a kind of hashtag going around, Truvada whore, with the suggestion that somebody who is using PrEP is a whore, is promiscuous, has a lot of partners. We need to be very, very intentionally positive about the use of PrEP. Because, and I do truly believe this, that when somebody decides they want to be on PrEP, they've recognized that there's some risk in their life for HIV, that their life holds some risk, and they're doing something proactive about it. It should also be noted that not everybody has complete control over condom use. And what I mean by that is, we see in our clinic teenagers, plenty of teenage girls, for example, coming in for STI testing. Many of those young women do not have control over whether their boyfriend uses a condom or not. Some of them have older boyfriends. Some of them are just not their relationship dynamic is such that they are not in a position to tell him to use a condom. Is that right? No, I don't think it is right that there's a thrown off power dynamic, but it is what it is. So we need to be mindful of that, but very positive about PrEP and its place in preventing HIV. The fact that somebody is putting their own health and wellness, their sexual health as a priority, and they're prioritizing the health of their partners, to me is only good. There's no negative to that. Potential barrier would be side effects. Most people on these medications experience no side effects. Sometimes and actually in very rare cases with Truvada, people could see a decrease in bone mineral density. That always returned to normal after they stopped taking it, but still, it was rare. Descovy doesn't have that as a side effect. Sometimes in the first week or couple of weeks, people get mild headaches, or they might get some GI issues. Side effects, though, are minimal. But it's a barrier if people think if they think the side effects are worse. And there is this idea, this knowledge that HIV medications can have significant side effects, although not the case here. Insurance can be a barrier. Typically, the only barrier that we have there is usually with teenagers or young adults who are on their parents' insurance. Medicaid covers PrEP. Almost all private insurance covers PrEP. We have funding through the state and through Gilead, the company that makes the medication, to be able to get people who are uninsured onto PrEP or underinsured or have a high deductible. We can take care of those guys. It's the only problem, the only ones we just keep struggling with are the kids on their parents' insurance, because, well, the ones who are on their parents' insurance and they don't want their parents to find out. That specifically is the problem, them not wanting their parents to find out, and we can't really work around that. We can prescribe PrEP to anyone, any age. Initially, when PrEP first came out, we needed parental consent to prescribe to an under 18-year-old. That's not the case anymore and hasn't been the case for a couple of years. But that may still be out there. There may be the misconception that you need parental consent for anyone under the age of 18, and that's not true. So I'd like to finish up. If anyone has any questions, you could write them in the chat box and I will happily respond, or the Q&A box that is also available to you. I encourage you, though, if you have any referrals or any additional questions that you think of after this webinar, to send me an email, drop me a text, or give me a call, and I will happily talk through anything that you're unsure of. We're taking referrals, although we actually don't need referrals, official referrals for PrEP. A patient can just call us and make an appointment. We don't need a doctor's referral. But if you're working with somebody who needs PrEP and you would like them to come to us, then send me a text, give me a call, send me an email, and we will set that up, no problem. Thank you very much for attending this webinar. I hope that you enjoyed it. I hope that it was useful and you are leaving with better knowledge of PrEP. Have a great day.